This is A Silent War Within, the podcast dedicated to confronting the unseen mental health battles carried by our first responder and healthcare heroes. This show is about real stories, real struggles, and real ways to survive the storm and come out stronger on the other side. For too long, stigma has kept you silent, but this is your space to bravely break that silence, share vital insights, and build a community where your well-being truly comes first, because your service deserves unwavering support.
So welcome to A Silent War Within. As always, we're happy to have you with us. We got our co-host, our new guest co-host. I don't know really what we're calling you. We're just going to go with it. MaKayla Davidson with us. And of course, you can always find us on our social media platforms and our website, silentwarwithin.com. Hope you guys have checked that out. I need to update it. I haven't put pictures of our newest guest as they come out. So I've been lax in doing that, and I hadn't made MaKayla a page yet. So I'm really behind, but we'll get there. It's always a work in progress. Today, we have a very special guest that I'm excited to have with us. I've watched her content for a long time. Alexandra Jabr here with us. Tell us a little bit about your background, what you do, and kind of your EMS background, because you've been in this for a long time.
Yeah, we were just talking about that before we started recording. I got started in this field in 2003, spent 15 years on an ambulance responding 911 calls, and my career was cut short abruptly by a back injury. So unfortunately, I don't get to do anymore, but because of the opportunity to teach, I've been able to stay very involved as an educator. And so I was already teaching at a college, working with paramedics, EMT students when the back injury occurred. So by the time I finally had to kind of retire from my position as a field medic, I was able to kind of transition seamlessly into education. Worked for a couple fire departments as an EMS coordinator. And then somewhere along the lines, I became a CE provider. So I started creating my own courses.
Right.
And that's the platform that you're probably most familiar with, which is Emergency Resilience. It's actually a school.
Yep.
So I have online CE courses.
Yeah, and super interesting content. One of the things, the videos when we were going back looking at, you as a guest and trying to prepare, one of the videos that I love the most, you did the 5 things that were 5 tips to help you with your longevity in EMS and your mental health. And some of those were start working with a therapist day one. So take your PTO regularly. I'm a big fan of that one. I love my PTO. And that's something that I'm a leader now, but that's something I tell all my associates that I lead is that, guys, that's your PTO. Take it. They always used to hate on me because I was, oh, you're never at work. You just take your PTO. I'm like, doesn't bother me a bit. You just say whatever you have to say. Always document the back injury. So the third one I wanted to stay on for a minute is this a learned lesson from you and your back injury that you didn't document the little ones and then the big one happened, or how did that go?
Oh, I was saved by the grace of one documentation that had happened several years prior to the injury exacerbating. So I had not had an acute back injury or like a recent strain or anything like that. It was my day off. I wasn't scheduled to work until that weekend. And I was just walking and all of a sudden I couldn't walk. Like my leg went out. It was a sharp shooting pain down my left leg. I thought my leg was hurt. I didn't know it was my back. It turned out that whether or not it herniated or it shifted just a little bit. I mean, there's a lot of different things that I don't understand about herniations, but I was told that you can live with a herniation for a really long time until you can't. So it can be asymptomatic for quite a while.
Mm-hmm.
And when my doctor got a hold of my MRI, because the MRI showed a 22 millimeter herniated disc, which if you're familiar, unfortunately, if you're unfortunately familiar with herniations, anything above 6 to 7 is considered very large. And mine was 22, and he took one look at it and he goes, "You didn't do this walking." He goes, "This is an old injury. Did you ever hurt your back at work?" Because he knew I was a medic. And I said, "Yeah." And he goes, "Well, I hope you documented it because you need to go talk to your supervisor about a workers' comp case." He goes, "This is way too severe of a back injury to not have been cumulative over, time." And I just happened to document it one time. I mean, I hurt my back several times at work. I'm ashamed to admit.
Sure, same.
And, it was always, but I never thought, there's always this denial. I never thought it was serious. I thought, oh, it's just my muscle. I pulled a muscle.
Mm-hmm.
No, your muscles are tightening
Always.
up because it doesn't want you to herniate something more. I mean, I'm not saying it's always that, but in my case, it was. And the only reason I documented it was I think it was the day before New Year's Eve. So it was the 30th of December. And I was going to work New Year's Eve. And I was transferring a patient from the gurney to the bed. It was our last call of the day. And I just twisted it just right. And I thought, I don't think I'm going to work on this tomorrow. But staffing had been so poor at my company at the time that they were giving final writtens to anybody that called off on holiday. And so I went into my supervisor's office that night and I said, hey, I want to write this up and I'm going to call off tomorrow, but I don't want the write up.
Yep.
I'm letting you know, like, I hurt my back. I can't work, or I shouldn't work, I should say. And he goes, you want to go to comp? You want to go get assessed? I said, no, just document it. I'll ice it, take a few Advil, I'll be fine. And that's all that happened. Didn't think about it for years until the doctor called me and was like, this is a back injury from work. And that saved my butt big time.
Well, that's great. I mean, it's great that not great that you injured your back, but certainly great that you documented it. That's a really good tip, because I can remember numerous back injuries that I've had that I said the same thing. Oh, it's just a muscle. I just pulled
Yeah.
something.
Oh, and
And
people will hurt it doing the simplest things. I mean, that was one thing my surgeon told me. He goes, look, you're going to blow out your next disc sneezing or getting out of bed wrong. He goes, it's going to happen the most, because I have 2 bad discs still.
mhm,
Knock on wood, nothing's happened yet, or, whatever. But, I was just watching a video from the salty paramedic. He threw out his bag
mhm,
reclining
mhm.
and was like, oh my God, and then if you're following the pre-hospitalist, she just posted today, she went to spit toothpaste out at work. And all of a sudden, or
And
not
it did,
spit, like she
yeah.
went to like throw her toothpaste in the drawer, spit out her like something with like her nightly routine. And she is laid out just in so much pain. And so a lot of people think like, oh my God, this is so stupid. No, that's tied to something else. That is tied to something you did at work. And, document.
Yep. Yep. And then the other thing you mentioned on number 4 was teaching and education as your backup plan, which obviously you've done
Mhm.
pretty successfully, I feel like. And that's always been mine. I did that very early, got my CPR instructor and just
Yeah.
built on that, and
Mhm.
that's what you said in the video. And of course, this one I wanted you to dive into a little bit. The 5th one, burnout
Mm.
is an unequal transfer of energy. So tell me about that. Tell me about your definition of what burnout is and what you've learned in your studies through your Ph.D. and through all the education that you've done about burnout.
I learned that from one of my therapists, actually.
Okay.
And I never forgot it, but it's something that once, like, she cued me into it, I couldn't not see it. Burnout was originally defined by, I believe, the World Health Organization, and it was specific to occupation. They did not regard it outside of that. And I think we've challenged that quite a bit. And I don't know that it's formally expanded to include life, but very much so, those things can happen. And what happens is when we don't have boundaries and we keep pouring ourselves into things that don't return, or we deny the receiving of help or the receiving of something from other people, because we don't feel worthy or we're just not comfortable accepting help, that it's eventually going to burn us out. And on the, let's take working, for example, like for me, I wanted a good shift. Like if I was to have the dream shift, it would be like a good shift, a
Mm-hmm.
good start time, a good partner, a good area, like not like a preferred area. And you can't have all of that stuff. But if I'm Friday nights with a partner who chews loudly in an area I don't like, with a dispatcher I don't like, or running, I don't know, like, I don't know how to explain, but if you have all these things that aren't, like, feeding back to you, you either have to change your circumstances or you have to change your attitude. It's like, okay, I
Mm-hmm.
either have to accept where I'm at, or I have to find some way to find enjoyment in my job. So if you don't like anything about your job, it is going to deplete you of your energy because you're gonna continue to put things into it that you're not getting out.
Sure. Yeah. No, I really like that definition, and that explains a lot. MaKayla, did you have something?
Oh, I was just going to ask Alex, for you, Kevin asked me this on my episode. What do you think that you do outside of work that pours back into you? What do you like to do to, relieve that tension?
That's a very good question. I think I've made my hobby my work, so that's a very tricky one for me now. But something I do currently. So I did not have a good relationship with hobbies or decompression when I worked in the field, or even when I was working as an EMS coordinator with the fire department. I remember when I first started dating my now fiance, he asked me, what do you like to do for fun? I said, I don't have fun. Like, I was like, I go to school and I work. That's all I do. And that wasn't a healthy answer, but that's exactly the state I was in for my whole career.
Mm-hmm.
And I'd say now I like novels. I love reading novels. So it has to be fiction. I have to get it helpful if there's been a movie or a TV show around that era. So I have like the picture of the like characters, but I love getting lost in a novel.
Oh, and see, now my son hates riding in the car with me because he wants to listen to music. And now that for the past probably 2 years, I have pursued the I guess highway of being a good leader and really digging into that. So we're always listening to Jocko Willink or Simon Sinek or one of those folks.
Yeah. Simon Smith's so good.
Oh, he's really good. He's one of my favorites. He's probably my favorite author that I've read in any of the books that I've listened to or read. And you may hear my chair squeak. It just made a weird noise. I didn't want y'all to think I had any kind of something crazy going on. But yeah, and he hates running the car with me now because I'm all, listening to books and listening to podcasts and things like that. And he just hates it. He inevitably ends up crying, begging me to play something else. And that
he wants to listen
happening.
to Biggie and Tupac, Kevin. Let the boy have what he wants.
Yeah. That first birthday party was pretty epic. For my son's first birthday party, we did a throwback rap party because the first birthday party is always for the parents. It's not really for the kid.
That's smart.
Anytime you have wine at a small child's birthday party, you get judged. And we did. But anyway, back to this. So after that injury, did you have kind of like an identity crisis or did you go through some type of depression? Because I certainly would. So I wanted to ask you that.
Big time. Oh my God. Big time. And it wasn't just my identity. Like, I didn't realize how much of my identity wrapped around being a medic. I liked being a medic. I liked being able to say I was a paramedic. I liked doing it. I feel like...
Me too.
Yeah, I feel like I had such a bad attitude by the time I left or was finishing up my time as an EMT. And then there was a transition point that happened around medic school where my whole attitude changed. And I just had a better attitude at work. I loved my job. I loved even the BS calls. I liked them. They were funny to me. I learned to have a really good attitude with it. And I was pretty good at it. I mean, I wasn't the best. I know there was still so much to learn, but I didn't suck at it and I enjoyed it. And when all of a sudden it literally changed from medic to patient in the blink of an eye, immediately. And it wasn't just the fear of will I ever be a medic again, which took a couple years to realize, no, I wouldn't, at least not in that capacity. I wouldn't be returning back to the ambulance. But it was this kind of it was very ego driven, but this idea that if I didn't do the job, I couldn't teach others how to do it. And so I really had to. And what's interesting is some of my favorite professors hadn't been on an ambulance this side of the millennia. They hadn't touched a patient since before I got a, middle school. And they were my favorite because they knew how to approach it. And I know there's some people that feel very strongly about it. But honestly, teaching saved my life. Those who can't do teach sometimes happens when you physically can't do. And that was my case. And so, but yeah, there was a big period of substance abuse, especially with alcohol. I was in a very unhealthy place. I weighed a lot more than I do now. I did not take care of my body. I did not take care of my mind. Even though I was in therapy, I wasn't doing, I don't think I was doing enough to offset the depression, anxiety. And I didn't actually get diagnosed with depression until 2021. So my injury happened, it was a few years in that finally occurred, and I started actually getting treatment for that.
So you have a really fantastic story, and I want to go back further than just the back injury because the way you got into EMS is really, I found a video on this. I went far back to find it. Yeah, I went far back to find it, but I found it so, heartwarming. I mean, it's Hallmark movie-ish for sure. Tell me about the two teachers, and you'll know what I'm talking about when I say that, but I want to hear a little bit more detail about that story.
My goodness. I don't know. I think I know what story you're telling about, and if it's that one, oh gosh, you're going to have to give me another I might be the one that's going to make me cry if you make me tell it.
It was two teachers that paid your way to, is that the one? Well, don't cry, or try not to. But I found that and I was like, this is the greatest EMS entry story that I've ever heard. So if you feel comfortable telling it, you certainly can. You don't have to if you don't want to. I can always cut it out.
I forgot I told that story. That's so funny. Gosh, if I remember correctly, let's see. So my mom was a teacher. She was an elementary school teacher, and she knew I wanted to go to EMT school after I was done with high school. And one of the fun things that I did to harass my mom as a child was tell her I wanted to be random things. Like, education mattered so much to my mother. And I don't think I appreciated that growing up. I hated school, actually. I didn't like it. I dropped out at one point in high school for a year, which is interesting because looking back, it was my undiagnosed depression and anxiety that led to that. And I didn't want to go to college. Ironic, I have a Ph.D. now. But my mom was from Mexico, and she was grew up very, very poor, where you were pulled out of school to work. Like, you were pulled out of elementary school. Nobody cared if you were missing. Like, you were there to, provide for the family in any way you could. She was one of 6 or 9. A couple of them died in childhood. And so, education mattered to her. So I'd come up with some random thing I was going to do. And then I'd like throw in a wild one, like, I want to be a race car driver. And she's like, that is not a career you can pick. Like, I wanted to be a photographer at one point. I had studied photography in school. She's like, that's not a career. And I was like, I want to be a teacher. And she goes, no, which she was a teacher. So it was ironic. So anyways, I told her one day I wanted to be an EMT, and she goes, that's a really good idea. And then she went to some event and met a woman who was a firefighter, paramedic, and she came home really excited because she thought, this is going to be a great thing for you. So it's the summer that she died, and she was at like a continuing education event for teachers, if I remember correctly, and she was supposed to make like $500 while she was there. And that $500 was going to pay for my EMT school. Well, then when she died, because she died right before Labor Day, which Labor Day was the start of school, like the 5th. And when she died, they couldn't find her timesheet for that event. So we didn't get paid for that specific event. And all her other bills, we lived paycheck to paycheck. So those things were paid for other things, and it was expensive enough to, bury her and all those things that come up with a funeral. And we were in probate because she didn't have her affairs in order. It was a mess. My sister was a full-time student at the time, 10 years older than me. She was finishing up dental hygiene school. So we were in kind of a compromising spot. And then those teachers put the money together to pay for me.
That is such a fantastic story. And now you have had this long storied career, and now you help hundreds and thousands of providers be better at what we do. And really, part of what you do is something nobody else out there is doing. It's really difficult to find somebody who teaches about what you teach about.
Yeah, Kevin, you did her so dirty, by the way. But also, sorry, my dog was barking.
Oh, I thought that was her laugh. Oh my gosh.
You thought that was me?
That was
I thought that was Alex's laugh. I was like, oh gosh. I wasn't going to say anything, but now that I know it was a dog, I could say that was a horrible laugh. So one of the things I find super interesting about what you do is you got a master's in death, grief, and bereavement. First off, why? That does not seem like something that I look at a list and go, that one, that's what I'm doing.
Yeah. Well, it was either that or my MFT in trauma, which would have been my marriage family therapist license. And I didn't want, it seemed like a likely outcome for me. I was already into, providing and advocating and doing the stuff I'm doing now, but I didn't want to work one-on-one with people. I wanted to stay in groups. I wanted to, stay in education. And by that point, I was already starting to teach death notifications. And part of, the fear around like whether or not I had the authority, maybe that's what I was looking for. Like, I thought, and I know I'm one of the only ones out there doing this. I know I'm not the only one. It's starting to pick up in trend, and whether or not I had something to do with that doesn't matter to me. I think as long as people are talking about it and we're getting this more widely recognized, because it is a huge deficiency in our industry. But I remember looking at that and going, oh, well, maybe after I get a master's, I can teach this. Like, I looked at it as a rite of passage, or like, I'll be worthy of teaching this now, or I'll be allowed to teach this now. And in reality, like, it gave me the confidence, but I mean, a lot of the stuff, and it did set the foundation, all the curriculum, everything that every paper I had to submit, every discussion question came back to death and first responders. And so it really laid a huge ground, foundation for me. And I will never say I didn't need it, but if I'm being honest, I sought it out because I was looking for the permission to create this. And I felt like I didn't have it from anybody. And so I gave it to myself with a master's degree.
So help me. This is one of the things that when I was in the field as a paramedic that I was deficient in. It was very hard to look somebody in the face and be genuine and be honest. And I have a big heart, so it was very hard for me to tell somebody their loved one had died. I did all the classic mistakes that you mentioned in a lot of your videos. They've passed away. I didn't use direct language. I would look around the room. There was no direct eye contact. I was just nervous about it. So
yeah, I made the
help
same
me as
mistake.
a provider, because I think that many providers struggle with that same thing. So what's some of your tips for somebody who's going to deliver a death notification to a family that's standing there that may have just watched you code their loved one?
Well, if it's a process and you're actually resuscitating them, then you can actually start the notification pretty early. And that's why I call it communication, death communication. It's not just the notification part, it's all the other elements that go into it, not only the body language, the paralanguage, our tone of voice, just the way that we're showing up. But I'd start off by, like, let's say you're the lead, medic, or you're the person who's going to ultimately deliver the news. Maybe you're, involved in the code and you get, your 2 rounds on board and you've assessed for, defibrillation, and people are, you've got the rhythm going on the resuscitation. You step away. You introduce yourself to that person who you're ultimately going to have to give that news to, and you tell them what's going on. And you tell them, you say that you don't know the last time you saw them. We're seeing this on the monitor. This does not look good. This is what we call asystole. It's a flat line. This is what we're doing to try and reverse it. We're doing X, Y, and Z right now. If that doesn't work, we're going to try again for another 10 minutes, but right now it's not looking good, and I just want to prepare you for that. We'll make sure to keep you informed. And then you can go back, and as you're getting near towards the end, you can, now you've involved them. They're involved in this. They're seeing what you're doing. They're seeing that you've, crossed all your T's and dotted all your I's and kept them informed of the whole process, that they're more likely, I should say, it's not always, but they're more likely to be accepting of the part where you have to tell them, okay, we're going to be stopping now. And you can tell them, and you can kind of not circumvent, but you can kind of go around the part where you say they've died up to that point, right? You don't need to tell them right away because it hasn't happened, right? Because they're still alive to them. Like, they're clinically dead to you, but they're not dead to the family member. That patient is not dead until you, as a point of authority, tell them that they're dead.
I think one of the best pieces of advice that you offer, and one of the things that we were talking about before I hit record, was, so Alex will take movie scenes, show scenes. What are you on, episode 5 or 6 of doing this? I mean, it's real limited. I mean, it's not every day you're doing this, but this is one of the things that I enjoyed, that she would take a clip, or that you would take a clip of that scene and break it down. And there was one from Grey's Anatomy, and I don't remember the character because I was not a huge Grey's Anatomy's fan, but the doctor's husband dies on the operating table. And she says, I need you to tell me that he's dead. I need you to say the words. Why is that the solidification for somebody to kind of start the acceptance or grieving process in itself? Why are those words so important?
Because there's no room for ambiguity. There's no room for shades of gray. There's no room for ambiguity. And in a state of fight or flight, and when we are acutely in a crisis, we don't understand euphemisms. We don't understand. There's something called negation in language. So if I remember correctly, one of the characters, I might be wrong, but one of the characters says he did not survive. When we say he did not survive, what the brain hears first is he did survive. It takes the not out, because the subconscious doesn't process things in the negative. It processes things in the positive. So it's going to say what you say. It's going to accept what you say first, and then it has to go back and then accept the not part. Not is called negation in language. So not, didn't, those kind of things, those things that change the structure of the sentence or the meaning of the sentence to mean the opposite. So it's not raining outside. I don't like broccoli. Well, I like broccoli if you take the word don't out. Okay. So it's kind of like that.
Right.
So you have to say it in the positive, not positive as in attitude, but positive as in present. What's the thing that's actually happening? So for him, I'm so sorry he died. Not, I'm so sorry he did not survive, because the brain's going to hear, I'm so sorry he survived first. It's not that the brain can't make it there. It just causes confusion for a moment, and they're in a state of denial. So what are they going to want to hear first?
Mm-hmm.
So you have to be as direct as possible. And with her, she was, in this case, I mean, such a great example, because she's getting into all her doctor talk. She's getting into surgeon talk. She's, just breaking down what they did clinically, instead of just telling this woman, her friend, that her husband is dead.
Yeah, and Alex, one thing too I want to add is, like, in the hospital, what's the first thing we do as providers when a person codes? We kick the family out.
Yeah.
So, and they're in the waiting room or they're outside the room and they have no clue what's going on. So they're sitting out there wondering, did the person make it? What's going on? And a lot of times we were told, even in nursing school, that'll cause trauma for the families. You want to kick them out. Not everybody wants to be kicked out.
No.
I mean, I think we should always give them the option. Do you want to stay? Do you want to see this? If not, yes. But I mean, not everyone needs that to be away from the situation. Not everyone's going to be traumatized by that.
No, in fact, some studies show that it
Mm-hmm.
decreases the occurrence of PTSD, depression, and anxiety after the fact, because they were given the agency to decide for themselves. Not everyone's going to want to see it, but almost everybody that's surveyed have said, I want the choice. They want the autonomy. They want the agency to decide for themselves. And of course, you have to put boundaries up. Like, we can let you stay in here as long as you do here. And if you don't, it's not tactically feasible, and you don't have the, manpower or the amount of members on the crew to have somebody stay with them and be next to them and act as their immediate liaison, then sometimes it's not possible. But when you can, letting them witness what it is, because people will say, oh, it's so traumatic, for them to see it. So is them being separated from their family member, especially if you're talking a parent and a child, because is that not it's arguably the worst thing they will ever experience. But then you add on the guilt of abandoning their child by forcing them out of the room to experience that by themselves. Like, no parent wants to see that happen. They want to be there in the suffering with their child.
Yeah. And plus also, I've heard a lot of families say this post-code, they didn't do enough. It's like that's their sense of trying to, like, grieve. They didn't do enough, or they could have done more. And I've personally found that when families are in the room and they've seen how exhaustive that resuscitative effort is, they really, they tried really hard to get them back. That's like goes through their brain. It's a complete paradigm shift.
Yeah. When you separate them, what happens is they have all these blank spaces in the narrative of what occurred, and they're going to fill it with emotionally satisfying conclusions, which is they died because they didn't do enough. Versus you keep them there, they have a full picture of exactly what happened, and they see exactly what you did enough. There's been cases, and I know one person personally, who are the ones that actually say, okay, enough. You've done everything. Thank you. They're the ones that call it. That's so powerful.
Mm-hmm. It is. And one of the wildest things that I've found, especially through your content, but also my personal experience, is when I would fumble that information of giving death notifications or starting that process of that communication. One of the things that, and I read it all the time in your comments, especially the stories that you share, you would say things like, well, we lost them. And the family's thinking, well, where'd they go?
Yeah.
If you kicked them out of the room and you say we lost them, well, where'd they go? Or
especially in a hospital. Hospitals are big.
Yeah. Yeah. And I worked in a hospital for a while as they were paramedics there, but basically a tech. The tech and the paramedic role is different there. But a paramedic, and there was a lot of times, because we had full paramedic autonomy, anything we could do in the ambulance, we were allowed to do in the ER. So there was a lot of codes that we would run if 2 or 3 critical patients come in at one time. And that was always very difficult, because the hospital wants you to take the family out of the room, like MaKayla was saying. So if you don't use the right language, they will very much misconstrue what you're saying.
Yeah, they're very literal. You have to be very literal, and you have to be very blunt. And you can be blunt and compassionate. I shouldn't say blunt. You can be direct and compassionate at the same time. Like, using the words dead and died are not dirty words. They're the most compassionate words you can use in that moment. And I tell people all the time, I've got hundreds of testimonies of people sharing experiences, because I look at usually when I share that kind of stuff on TikTok, it gets in front of a lot of the layperson. Whereas my community or the people, my audience on Instagram gets in front of a lot of medical providers. So when I share that stuff on TikTok and it gets in front of the layperson, there's so many experiences they share about how they were told poorly or how they were told unclearly that their loved one had died. And I have hundreds of their
You've got
comments
so many testimonials.
cataloged, and not once, and I tell everybody this when I teach this, I said, not once, and I promise you, when I have somebody tell me this, I promise I will include it in this part of my lecture. Not once has someone complained that somebody was too direct or honest with them.
That's so powerful. Yeah, especially in the hospital. They need to hear that. And for providers too, I'd love for you to touch on this because this just happened. We had an extensive code that lasts over an hour, and I talked to one of my friends about this. As nurses and healthcare providers, when you're doing a resuscitative effort and you're trying to get that person back, that person becomes a body because you're so task driven. It's not a person in your mind because you dissociate from that as providers. And then after that person passes, we put the pictures that the family gave us on their body, and then the family comes in. It kind of in your brain reconnects that this is a person, this is a father, this is a husband. And then that's when, for me, that really tore a chunk out of my heart because, the whole resuscitative effort, it's like task driven, trying to get this body back to life. And then they come back and it's like a real person. And then, that grief and debrief starts. Can you
Yes.
talk a little bit about debrief for, what you do?
Oh yeah. No, what it sounds like what you were describing is it humanizes them. And all of a sudden you're not in this paramedic or nurse role. You're connecting with that family as if you were the daughter or that was your child or that was your father. And then there's this projection and this and that what you're describing actually is empathy too. And that's what makes us so scared of empathy is it's a very vulnerable feeling. It's a very intimate feeling, especially to feel that for somebody you don't know. But the thing, and I'll say this before I talk about the debrief, is that we, empathy is such an important tool, but it's not meant to stay with us. We're not meant to carry that with us. And there needs to be something that we do that discharges that, feeling, whether it's going for a run, whether it's going and grounding, feet in the grass, go hug a tree, something that go meditate, something to say, I'm releasing this. This is not for me to carry. Or it's something you work out in therapy, EMDR, ketamine therapy, processing talk therapy, something. But it's not for you to keep and hang on to. Otherwise, you get burned out, unequal exchange of energy, and then you deal with compassion fatigue. And so as far as the debrief goes, I actually haven't been a part of very many. I can say with quite certainty, the only debriefs I've been a part of after a hard call were on the tailboard with an ice cream cone in my hand in the bay. And those were fantastic, but I couldn't tell you how a formal, I was doing this when CISM, CISD debriefs were just a part in chapter 1 of your EMT book. It wasn't something you actually saw done. But I can tell you from my understanding of the way the psyche works, one of the most important parts of a debrief is that everyone is present for it. And so what I tell people, I had somebody call me one time because they had a really bad drowning and they knew one of their guys was not doing well because he had a kid the same age who was at a birthday party, a swim birthday party at the time that this happened. So he, of course, that's where his head goes. And this person calls me and he goes, "Hey, our chief is trying to force this guy to go to the after act, the debriefing thing. And can he do that legally?" And I was like, "No," but I was like, here, as far as, we're talking firefighter bill, all these not firefighter, policies, sorry, standard, the standard of procedures kind of thing. And so we're talking those kind of things. I said, that aside, I said, here's how you get him there. You find someone else who is there and you say, "Hey, can you go for me?" And so you take the spotlight off of the person that quote unquote needs it because someone saw them struggling. And you say, "Hey, it would help me if you were there with me for it. If you can't go for yourself, can you at least show up for me? You don't have to do anything." And so that's kind of how you decentralize the person who probably needs it the most, that doesn't want that kind of attention, is you turn it around and say, "It would really help me if you were there." Because that's what we do when crisis happens. We reach out to the person who was there. We reach for the person who was most intimately involved. That's why if you know somebody that died, that went to the hospital or was, 911 responded to them, you want to know who was on shift. Whose shift was it? What, jurisdiction, and you want to talk to them just to know who was there.
Yeah. And Kevin, you talked about this too, about like you had a difficult code situation and then you were questioning, like, did I do everything right? That's really, I personally in the hospital, we're really trying to implement post-code huddles or,
Yeah.
debriefs.
Yeah.
And like, you think, did I make the right intervention? Did I call the rapid response or did I call the code blue fast enough? Was that medication that I gave correct? And a lot of times you second guess yourself. That's just common human nature. And then when you debrief with your peers, you're like, no, actually, that was right. I think you talked about that, Kevin, a few episodes ago.
I did. I had a child drowning, and the child I was working on was the same age as my daughter at the time, and it was very difficult. It really shaped and catapulted my career in a way that even I didn't recognize at the time. And it started this buildup of things that I just suppressed and suppressed over time. And it all blew up all of a sudden. And I was like, oh, well, it was that. Like, I can see where it all started. And it kind of got that. And it really catapulted me into the love that I have today for mental health. And it really goes into my next point is, so this is obviously a really heavy topic that you deal with on a regular basis. Why is it so taxing for us as providers? And MaKayla mentioned some of the points, but why is it so taxing for us to provide as providers to have that empathy and begin to humanize somebody? I always found that very difficult. I hated that part. Like when I would step back, because as long as I was task oriented, it, like MaKayla said, it was just somebody. It was just a body. I had a job to do, get it done. But then when you start to humanize, it's like, oh, that's so heavy. I don't want that. And it weighs on you. So why is brain science wise, why is that so taxing to us as providers? And how can we kind of move away from or learn how to deal with that a little better?
Well, two things, and I want to bring it back to something you said, MaKayla, about the debriefing. I completely forgot about this because, that's exactly what happens is it's almost like an after action review where you're talking about what steps did everybody take, and people get to have their fears either validated or dissipated in that moment. And what you're describing is actually what I think fuels moral injury. And moral injury, we're going to start hearing a lot more about moral injury. And I would put it right up there with PTSD. If not a silent co-occur or maybe even mistaken for, I wonder if moral injury has been the problem all along. Like PTSD still is, but the way moral injury has been silently just lurking around every decision and every mistake that we've made. I mean, I can totally see that being the case. And that's an opportunity to get your facts straight. And then also go, okay, did I make a mistake? Let me learn from that mistake, as opposed to being shamed into, secrecy and silence and judgment. Now, the question you're asking is like, that is a heavy load. If we don't take care of our own feelings, how are we going to manage anybody else's? And something first responders are fantastic at is compartmentalizing, disassociating, but they don't know how to take that armor off and actually feel that. And so we just keep shoving it down, shoving it down, shoving it down. And there is a quote that's largely attributed to Sigmund Freud, which he didn't say this exactly, but this does reflect the work that he did, which is that unexpressed emotions never die. They will get buried and they'll get buried alive and basically come out in uglier ways. And so there's a really great, I don't know if you saw the clip that I shared of the pit where Noah Wiley is breaking down in the peds room where he's going, it like basically comes to a breaking point. That is exactly what happens when we keep shoving it down. It's because he has not processed them. And when we don't process them, they get buried, as in when he says they get buried alive, he's saying they remain alive so that when they revisit us, it's as if it's happening right there in that moment. And that is classic PTSD. It doesn't get filed away as a memory that happened in the past. It gets filed away as a present threat that happens right now.
And that's so scary because you don't even know what's going to trigger that.
No, you don't. You absolutely don't. I mean, and if you watch that clip, the reason I love that, I'm so proud of that actually, because it's like the scene is perfectly timed with, and I didn't do this. I mean, it's just organically happened by itself, but it's perfectly timed with the podcast that Noah Wiley's on while he's telling the story about how his mother, who is a retired nurse, was triggered by his scene on the TV and her own patient memories came up out of nowhere. Like, isn't that wild?
That's
Ab-
crazy. Yeah. It comes out of
abs-
nowhere. It really does.
It does.
If you
and
don't deal with it. I think that's
Exactly.
the main thing about Kevin's podcast that I love.
Yeah.
It's bringing light to all these issues. I'm getting so much out of this episode, just so you guys
Good.
know.
Okay.
yeah, but I think one of the hard things, and the thing that I had to learn the hard way, and I think it may have been 6 or 7 months ago, I run across one of your videos and completely related to what you said, and it was kind of funny too. I mean, you just looked disheveled and not put together, and you said, I wish somebody would have told me that I'm going to feel worse when I'm processing all my stuff first. And I had to learn that the hard way. Like, I
Yeah.
was going to my counselor weekly going, this sucks. Like, all of this sucks. I don't like this. I don't want to do it anymore. You know, I feel worse than when we started. You're supposed to be fixing me. And that's what I thought. That's not the point of it. But you're supposed to be fixing me. And I don't feel fixed at all. I feel worse than when I started.
Uh-huh.
What's the deal? And it took me a while to go, sometimes it's okay to sit with those feelings for a little bit and feel them and let them wash over you a little bit, because it brings about healing when you start to go through those steps of humanizing and empathizing and then grieving in your own way and then going about your day and having those thoughts. I felt like it was therapeutic for me to go through all those steps, but at the same time, it still sucked.
Oh, it does. It does. And I think I like to think of them as those feelings are coming back up on their way out the door. I know that's not the way it is. I know I'm never going to, it's a continuum, right? So, I might process that one, but there's always something more to be excavated. Our capacity for emotional feeling and the diversion of it as well, our avoidance of it is very high. And so, one of the things I always, like to keep in mind about the healing is I come back to what it was like when I had my back surgery. So eventually I had my back surgery. It was several months after the injury, like really exacerbated. And it was the herniation had put a lot of pressure on my sciatica nerve, a lot of pressure. I mean, I had pain from my hip to my toe.
Oh, that's so painful.
It was not fun.
It was awful.
And I had numbness. I had atrophy to that leg. I had a lot of problems afterwards. So even though the surgery took away most of the nerve pain, when the nerves started firing together and I started getting it back, man, I had the sharpest like pains down my leg. It happened yesterday. Once in a while, I'll just get a little sharp pain. And it's almost like, okay, it's healing. It's coming back together. What I wasn't feeling for the longest time, what was bothering me for numbness is now, this is having more sensation is actually an indicative of healing, even though I'm feeling more of it and it hurts. But that's kind of how I kind of connected that is, and one of the things that, at least with ketamine therapy and really all therapy, is it's not necessarily about feeling better. Like, yeah, that's the ultimate goal. It's about getting better at feeling.
So I don't know if you know this creator, but Jake Belay was on our show a few weeks ago. He's a trauma coach and former police officer, but he talked about ketamine therapy, and I knew about it, but I was pretty unfamiliar. So can you walk through what is there a typical ketamine therapy, or is it just kind of person based?
Yeah, the person can be the variable, but the practice is really the biggest variable. So, and I'm not judging how any one practice does things, but I can tell you what my preference is it is not a heavy clinical type of setting. So there are some practices that have opened up that, look like an urgent care. They just, draw the sheet, leave you in the bed, let you have your trip with the infusion, bright lights on, all this stuff. They might monitor you on the wall and then they check in. Okay, bye. Like, go ahead and leave. Or they put you in a chair or something like that. That's not how I did my ketamine therapy. My ketamine therapy was, it was kind of like going to a spa, you go
That's
in.
what it looked like.
Yeah, you go in, you got the nice, essential
The
oils.
projector on the wall.
I brought that for me. Like, I like having the projector.
Yeah.
I don't know. It's just, I have my blanket, I get myself settled in. It's a nice comfy chair. I feel safe. It's in a, safe, clean environment, and I've got, practitioners there, but it's basically, at least for IV ketamine because there are a couple different ways that you can participate in it. And I've mostly only done IV. You go in, you get your vitals taken, they hook you up to the monitors and stuff and make sure that you're good to go. They have to screen you for high blood pressure. They start the IV and you go on your journey and you listen to your music. You have your music to kind of help guide it. Really helps with it. And then, you feel yourself coming down. You feel yourself lift off. That is one of the first hallucinations you have is lifting out of your body.
I'm just very interested in it. It's not something that I was really familiar with until just here recently, starting this podcast and hearing more and more mental health professionals like yourself talk about it, recommend it, give their testimonies about doing it. So I really think it's an up and coming thing more so than because like I said, I had never heard about it, but just hearing more
Yeah,
about it
Kevin,
is
I've
super
never heard of
interesting.
this. This is the first time I'm hearing of this.
That's super interesting.
Yeah. Well, this will be a good time for me to plug. I do have a continuing education course on ketamine therapy. It is 2 hours worth 2 hours of CEs for EMS providers, and it is completely free. 100% free. You can go ahead and find it on my website, emergencyresilience.com. Go to the CE courses, scroll down, and I just released it actually. And this was kind of something I sought out to do at the beginning of my PhD program. And I didn't know I was going to study ketamine therapy when I got to my dissertation. But when I did, I ended up studying ketamine therapy for PTSD and all the other friends that PTSD has: depression, anxiety, addiction, suicide, all those things. And so that's what I published my dissertation on. And then I waited until I was done with my dissertation to embark on my own work with ketamine therapy. And so I was a fan as a researcher, and then I was a fan as a patient. And I can say as a peer and advocate for it that it is a very good tool for many people. I will never sell it as it is great for everybody. I will never say it works for everybody or that it's the only thing you need. It has to be paired with talk therapy and a lot of different things. You have to use it as a tool to help you change. It lets your brain and the pathways in your brain become more malleable. And you hear the term neuroplasticity. How do we change our mind?
Mm-hmm.
There's a really good book called How to Change Your Mind. Literally, that's what it's called, by Michael Pollan. Highly recommend it. And it talks about how these help to facilitate that change so that you're not stuck in this old subconscious programming that keeps self-sabotaging your life and reaching for the wrong things and creating the same behaviors that lead to the same problems over and over again. It kind of helps you it just gives you a leg up into changing that.
Do you feel like there's still a stigma related to these therapies with peers?
Oh yeah. And so funny because I'm like, okay, we switched out the PTSD stigma for the mental healing stigma, but
Mm-hmm.
I haven't posted too many things about this thing yet, about this course yet. But of course, when I did, there'd be, and it's always people that aren't part of the community already that don't know my work. And they're just, posting, I don't know, Matthew Perry memes and stuff. And I'm like, thanks for the attention and the engagement, but or people like someone said this is the worst idea ever when I posted the CE class, and I was like, okay, thanks.
Thanks for your input.
Thank you.
I really do find it extremely interesting, and I'm with you that it's not a one size fits all kind of thing. Like it doesn't absolutely cure everything. There's parts and has to be kind of woven into a treatment plan.
Sure.
But is this something typically that has to be referred by your doctor, or or are these clinics that you can walk in and get screened for and then do it, or how does it usually work? Because I'm interested in the details. Really are important
So
to
the
me.
practice that you decide to go work with will have a prescribing clinician. So this is completely legal. And the number of times that people will reach out to me and be like, hey, how do I get a ketamine? It's it's not Google it. Google your nearest large city, you will find a ketamine practice. And there's, some things I recommend. I don't recommend one ketamine. There's only one ketamine practice I actually would recommend because I've worked with them before, but publicly I don't associate or align with anybody. Instead, I teach you how to find your own. And that's also a handout that's found in the ketamine course. And it's one of the lessons in the modules as well, is to discuss how to select a ketamine clinic and what are the things you look for. I'll tell you, the number one thing I look for is when I'm sitting with the clinician, I go, what's your experience with ketamine? Your personal experience. And if they tell me they've never done it before, I'm out. There's no reason why a provider should have not done their own work, because in order to go through the ketamine training, which is not required, this is kind of a willy-nilly, kind of scope for some people. Like an anesthesiologist can just decide that they want to open up a clinic without any mental health components or regard whatsoever, no integration, like not really understanding the psychospiritual element of it. And that, I'm not saying they won't still get results, they will, but there is a more integrative way to get your money's worth, your money and your time worth. And it's not through a drip clinic. And so, I would say you look up where your local places are, and then you go ask questions like that. Ask what their experience has been with it. Did they get CAP trained? Like, are they trained as a facilitator? Did they go through any type of training to be a provider? Because there's a lot of mystical stuff that goes into this, and your average physician and really clinician altogether, not just physicians, but don't really like the word mystic. They get kind of weirded out by it.
Yeah, and
So
plus, I can tell you firsthand, I have a friend right now who's struggling with some long-term health issues in the hospital. She's a nurse, and she's going through some alternate, medicine therapies to help deal with those chronic issues. And I'm going to just be very blunt. It's been very stigmatized by leadership, hospital administration. They're kind of scared of those things. When you start
Yeah.
talking about, there's a nurse on this floor going through ketamine therapy. What would you say to those leaders that are still skeptical about, us prioritizing our mental health?
I mean, I think the best way to challenge stigma is through education. I would have them, that anybody who, and that's where my, I guess, rebuttal to anybody who's in the comments of this course want to say anything, take the course and then we'll talk. Like I'm more than willing to hear out what your concerns are, but it's usually from misguided information or just a misunderstanding, because I understand that there's a lot. Most of the time you have to also recognize that it's coming from a place of fear. And then they have to just better understand that the it's not just a rave drug, it's not just a horse tranquilizer. It's been used for a number of reasons in a number of ways, and for a lot of people it's saved their life. And why wouldn't somebody try and find relief somehow?
yeah, and in the EMS side of things, it's been on our ambulances for years now.
Yeah.
We use it, especially in the pediatric world. My organization is strictly pediatric critical care, and we use it a ton over any of the other analgesics that
They do
we've
well.
used for years, and they do well.
They do very well with it.
I did have a child tell me that I was a fairy with wings and I was flying around the room, but
Good.
that doesn't sound that bad, actually.
No, it doesn't
Is that
sound bad
what's
at
in
all.
the green whistle? I don't think we utilize it in the United States a lot, but is that what's in that green whistle that other countries have that people can like inhale?
No.
I don't know that one.
That sounds interesting though.
I watch a lot of that, like where the Bondi lifeguards or whatever. And
Yeah,
when,
I've seen
yeah,
that.
Yeah.
and they have the green whistle. So when people are in pain, it's like that I think it is ketamine. I'm pretty sure.
Oh, interesting. I wouldn't be surprised.
No, ketamine's a
Ketamine's
great
like duct
drug.
tape now. Like you're just using it like mag. You're just using it for everything.
Yeah, ketamine's a great drug. I've used it multiple times, and I love the results I get from it. I'm just interested in the mental health part of it because a couple of weeks ago was the first time I had heard this. I was like MaKayla. I was ignorant to the information that was out there. And now that I've found your course on it, because I didn't know you had a course on this. I knew you had a course on the death notification. I knew you had a course on, what is it called, when they're doing CPR and they actually wake up during the CPR.
induced consciousness.
There you go. CPR-induced consciousness. And this is a really interesting phenomenon that I've only seen once in my career. So to have somebody else out there, and that was with a Lucas device,
Yeah, I believe
and
it.
Memphis Fire rolled them into the ER, and they were trying to talk and looking around. And I was like, this is the wildest thing I've ever seen in my life.
I've seen it once and it scared the crap out of me.
Absolutely. And it's even much worse when the providers, like, I have to ask you, did you know what it was before you experienced it?
No,
did you-
I'd never seen anything like
I'd
that.
never seen that before. VTAC, no pulse. We're doing CPR and he is looking straight at us. Am I going to die? I was like, oh my God.
They don't teach that, but they should.
No, they don't teach that. I'm super excited to take your courses. So one of the things that you've done is create this really awesome, I don't know if you'd call it a platform or a
Community.
Community. Yeah, absolutely. You've created a community and a platform, of course, Emergency Resilience, that teaches not just the death notifications, but some other stuff as well, and your TikTok does well, and all the other places that, that you've got information. Even the things you share in your LinkedIn are extremely interesting to me. So I guess give us your shameless plug. I love a shameless plug section. I'm
Okay.
super excited to take some courses with you now. I've always enjoyed your TikToks, but it was just recently in researching it, I was like, oh, she's got all these actual classes. And you talked about it on your TikTok, but you know how TikTok is. People scroll by when you start,
Selling.
mentioning, yeah. But now that I found it, I was like, this is great. I'm going to
I'm
use
gonna
this.
take all her classes for my license renewal.
Oh,
Yeah.
thank you. Yeah, I appreciate that. I mean, I really do appreciate it. It's how I make my living now. I mean, it's this continuing education school. I'm very grateful. I'm a CAPC, accredited organization, so I have a lot of agency to create. Like, I have kind of an attitude about CEs. Like, I hated continuing education for the longest time. Of course, that kind of was something I outgrew with maturity, but
Mhm.
also I realized like a lot of continuing education isn't good. If it was just better and more interesting, then maybe I wouldn't have hated it so much. Maybe it was the quality of the education. So being able to kind of take the reins and create some education has been, I would say, a creative outlet for me. And so a lot of I mean, my stuff is trauma informed. So I always have an element of mental health that goes into it. Even on a topic with CPR-induced consciousness, one of your most common risks is actually moral injury with that. Because do you medicate them and risk not getting a pulse back, or do you let them suffer while you're intubating and, holding their arms down? There's a huge moral risk there. So yeah, I only have I'm like kind of I'm a very like, I don't know, like farm to table boutique CE course. Like you're not going to come to me and get all 48 hours or 72 hours. You need to go to Foam Frat or something like that for that, which I work with them as well. I do have a series on there on Foam Frat's channel.
Do you
And
really?
I do. So if
Oh
you're in the
yeah, I
studio,
am. Yeah.
yep, I have a season on psychological injury, and we talk about moral injury, administrative betrayal. We talk death notifications. What was the other one? Disenfranchised grief, and then one on ketamine.
I love Foam Frat. They are the reason I've been a paramedic for the last 2 cycles of renewal.
It's awesome. Yeah. And so if you're looking for like all encompassing and to, something that meets your state's requirements, that's going to be who you're going to go to. If
How
you
do
want
we
to
find that company? What was it?
Foam Frat.
Foam Frat,
Mhm.
just look up that.
Yeah.
I mean, my company pays for ours and
That's
all of our
awesome.
associates, but that's a platform because we're hospital based. So we didn't have anything for the EMS people that worked for us. It was just
Yeah.
all nursing education or all respiratory therapist education. And we got that for the EMS side of it. And it's been fantastic.
Yeah. And
Tim,
they're
you'll have
really,
to link that in the show notes for
yeah.
I will.
everybody.
Yeah. And I'll definitely link your page too, Alex, because I think that's good stuff.
Thank you. And yeah, so when you come to me, you'll get a very, like I said, a niche topic. And a lot of times the courses that I have so many courses that are in draft mode that I have not finished or released, they come from the conversations that come out of the community. So I feel like this is very much a co-creation. And so when people tell me that they're interested in something or they're struggling with something or they need to understand something more, then that's what motivates me to create it, on top of the fact that I just want to be interested. Like if I'm interested in it, I get hyper fixated. It makes it a lot
Mm,
easier for me to finish it. But, I kind of look at something and instead of saying like, is this eligible for CEs? I get to say, what can I do to make it CE eligible? And then I'll do it.
that's awesome. Well, I think that we have reached at least near the end.
Yeah.
I could probably talk to you for many, many more hours because I am a talker and I have enjoyed this conversation. But thank you for joining us. Tell all our people one more time where they can find all of your content, your material, other than emergencyresilience.com. It is.
It is. It's emergencyresilience.com, and my handles are all the same at Emergency Resilience. I'm mostly on Instagram and then TikTok in that order. So, but you can find me on
Mhm.
all of them.
Well, thank you so much for joining us, MaKayla. Thank you for filling in again.
Alex, thank you. I got so much out of this episode. I know people are like really going to get a lot out of this one. It was really good.
Awesome. Thank you
Yeah,
so much
yeah.
for having me on. This was really great. You asked some amazing questions.
Well, thank you. And of course, you can catch us on all the social medias, the same places you can find Alex. Unfortunately, MaKayla is anti-social media, so you're not going to find her anywhere.
Oh, no.
I
I
do
know.
have Instagram. It's just private.
That's
Yeah.
fine. I
Yeah.
respect it.
this is her first public anything. Like she
Okay.
doesn't do the TikTok videos. She had a really good episode, and I said, well, you're in.
Nice.
But again, thank you for being with us. We really enjoyed our conversation. And like I said, guys, you can find us on all the socials. You can check out our website. And as always, to close out the show, we will do our same slogan that we've done forever. Be safe, take care of your mind, and we will talk soon. Thanks for listening, everybody.
You've been listening to A Silent War Within. If this episode resonated, please subscribe, leave a review, and share with someone who needs to hear it. Remember, you're not alone and your well-being matters. It's time to end this silent war.